Hello, good evening, everybody. Can you hear me?
Yes, I can, ma'am.
Perfect. I had a few issues with my mic yesterday, so it seems reasonable to double check even though I've checked. You're all welcome again to the Nigerian Orthopedic Association Zoom learning session for the day. We have been working through parallel curriculum with hand and upper limb now on Saturdays, and then the hip and pelvis on Sundays. And this will be about the 50th meeting, I think. So thank you very much for everybody who has been committed to this course. Thank you for the knowledge you have shared. Thank you for your participation and your encouragement and commitment and support. Per our usual protocol, please stay muted. I'm wondering whether to just mute everybody on entry like we did yesterday, because I think that worked really well. And then you can unmute if you have questions or comments later on during the course of the talk. So I'll just do that now. Yeah, fixed. Okay. And today we're having a talk that is para-orthopedics, because we're going to be going towards the pelvis, but we'll be sitting more around the soft tissues of the pelvis. We'll be talking about urethral injuries in pelvic fractures. Pelvic fractures are injuries that can range from the simple to the potentially devastating. And fortunately or unfortunately, they will tend to come to us first. But sometimes we need our urology colleagues to help out with the management of urethral injuries, which could occur. So I'm very pleased to have that as our topic for the day. I'm very pleased that we have in our midst Oluwatomi Odutola, who is a second-year specialty trainee in urology, and she is a member of the West Africa College of Surgeons, and she's an associate fellow of Nigerian postgraduate, the National Postgraduate Medical College of Nigeria. She's also the chief resident of the urology department at the University of Benin Teaching Hospital. She's a member of the International Society of Urologists, of Bloodless Medicine and Surgery Group. So I'm very happy to welcome her to our platform. She's an associate orthopedic surgeon as well, because she's probably attended almost all the lectures we've had on this platform in orthopedics. I thank you, Tomi, for your keen interest in patient care, your commitment to excellence, and your commitment to the Orthopedic Association by proxy. So may I welcome you very warmly to speak with us today. We're glad to have you. You're a member of the house, really. Probably attended more orthopedic sessions than some orthopedic residents have. So feel free.
Good evening, ma'am. Thank you very much for having me.
You're welcome.
Good evening, everyone. I was wondering if I could go ahead and share my screen now.
You should be able to, because I made you a co-host already.
Okay. Is it up now?
Yes, it is now.
Okay. Trying to put it on slideshow. Okay. Good evening once again to everyone. Am I audible, please? Please, am I audible?
You're audible, but your mic is moving a bit because it's on one side. So maybe you should, I'm not quite sure, fix it in some way.
Because I'm using my earpiece.
Yes. Just note that if it moves, the sound fluctuates, that's all. But you're audible, reasonably clear.
Is it better now, please?
I think it's fair. Could we have a comment from somebody else in the house? Just in case it's my own mic that's making it. Is everybody happy with the sound? Oh yes, I know.
Hello, ma'am.
Oh good.
Yes, the sound is clear.
Perfect.
Okay. Please let me know when I should go ahead.
Please go ahead.
All right. So good evening once again to everyone. This evening we'll be talking about urethral injuries and pelvic fractures. And I'll be using this outline. Okay. Now, pelvic fractures result usually from high energy blunt force trauma and can cause injury to the posterior urethra commonly. And these injuries are described or named pelvic fracture urethral injuries. Urethral injuries are not necessarily urethral strictures, especially with regard to injuries involving the posterior urethra. Most pelvic fractures, when they occur by themselves, do not necessarily cause urethral injuries. However, the patient suffers them as a result of rupture of the ligamentous attachments during the disruption of the pelvic ring on impact from the trauma. And this usually occurs when it separates the urethra from the attachment. Now, for the urethral injuries that occur from a pelvic fracture, they're usually either the bulbar urethral injuries or injuries involving the posterior urethra, which are the membranous and the prostatic urethra. They are not really strictures in themselves by definition, but they are rather more appropriately called distraction injuries. For us to call a urethral injury stricture, it usually is the end result from different or varying degrees of urethral injuries that has resulted from chronic inflammation that ended in fibrosis and loss of distensibility of that segment of the urethra, causing a narrowing that can be partial or complete. That is what we refer to as a stricture. However, injuries that result from pelvic fractures that usually involve most commonly the bulbar urethra or the posterior part of the urethra, which is the membranous or the prostatic, are not really strictures in themselves. They are more called distraction injuries for those involving the posterior urethra. And the primary management of urethral injuries is dictated by the advanced trauma life support protocol because the patient's life needs to be safe first before we come down the ladder to sorting out the patient's urethral injuries that have been sustained. And it's when the patient has been hemodynamically resuscitated that attention may not be diverted to sorting out the urethral injuries. The management of these patients are usually multimodal and multidisciplinary, involving the trauma team, the urologist, the cardiothoracic surgeon, depending on the associated injuries that the patient may also suffer. And of course, the orthopedic surgeon for the patient who has an associated pelvic fracture. Taking a look at anatomy, the key thing I want to bring out in this photograph is the close relationship between the urethra in the female and the male to the pelvic ring. This pelvic symphysis anterior here, and this part of the urethra, this is the membranous, and then further up here is the prostatic urethra that's surrounded by the prostate and then the bladder neck. Okay, so different types of injuries to the pelvic ring at this joint can involve usually the posterior part of the urethra, and sometimes the bulbar urethra is involved. This retrograde uretrograms better outline the lumen of the urethra. This normal uretrograms, what it should look like normally. And the membranous urethra is known to be the most narrow, the most physiologically narrow part of the urethra. And you can see the smooth outline of the mucosa here, and then the gentle bulb, the bulbar urethra here, and then the membranous urethra, prostatic urethra up here into the bladder neck, as also depicted in this photograph to my right. Goldman classified urethral injuries to help characterize them, and this mainly for the posterior urethra. For the class 1, the posterior urethra is stretched, can be contused, You have some hematoma, but the lumen is intact. For the type 2, there's a partial or complete injury with a tear involving the membranous urethra. However, the urogenital diaphragm is intact. And when a ultrasound is done in the emergency room, contrast is seen to extravasate above the urogenital diaphragm. In type 3, there can be partial or complete anterior and posterior urethral injury with disruption of the urogenital diaphragm. So on the injection of contrast to the trauma setting, contrast is seen to leak above and below the urogenital diaphragm for the class 3 type of injuries. And in type 4 is when we have a bladder neck injury that extends into the urethra. And in type 5 is a bladder base injury with periurethral extravasation. And then on contrast administration, there's extravasation of the contrast around the bladder neck. In type 6, we have the partial or complete isolated anterior urethral injury. Now, the American Society for the Assessment of Trauma further helped to describe the degrees of urethral injuries that will help with planning operating management. So for the class 1, it describes contusion, where the patient on presentation also has blood at the urethral meatus, and then the retrograde urethral study is normal. The extravasation on contrast of the retrograde study. In type 2, patients have suffered a stretch injury, there's elongation of the urethra. There's also still no extravasation of urethrography. For type 3, there's a partial disruption of the urethra, causing extravasation of the contrast medium when it's done at the injury site. However, contrast still gets into the bladder. For type 4, there's complete disruption of the urethra and there's extravasation of contrast. However, the defect is less than 2 centimeters. In type 5, there's complete disruption and extravasation with a defect more than 2 centimeters. Now, to talk about grading of pelvic trauma, I would like to talk about it based on the energy exchange from the impact of the injury. We have low and high energy, which the low energy kind of pelvic trauma occurs in about 1/3 of cases, and it's usually an isolated injury. There's usually no damage to the integrity of the pelvic structures. It usually results from domestic falls, sports injuries, and then low velocity impacts from vehicular accidents. The high energy type of trauma accounts for about 2/3 of cases and usually results in multiple fractures of the pelvic ring. They are usually associated injuries to the central nervous system, to the chest, and the abdomen of these patients. And the patients are usually, these are the drivers or pedestrians from motor vehicular accidents that may have been run over or impaled against the wall. And of course, in patients who suffer falls from heights that are greater than 4 meters, it could also come down with pelvic fractures. Young and Burgess classified pelvic fractures. I think it's more familiar to the orthopedic surgeons. But importantly, the type of force that caused the injury used to subdivide the types of pelvic fractures. A lateral compression force could occur, and we have 3 types of fractures that could result from application of lateral compression, either to the right or the left side of the patient. We have the anterior posterior compression forces, and then of course the vertical shear usually occurs when the patient falls from heights or there's an active deceleration injury. For patients coming from an upper to a lower point of contact, and of course we have combined injuries that could occur from patients who are hit and then climbed over by a second vehicle. This slide just describes the fractures seen on the different types of forces that could fracture the pelvic ring. This here is an X-ray showing the disruption of the pelvic ring here from a fall from a height for this patient. Okay. This also describes what we see from anterior posterior compression forces that result in pelvic fractures. This radiograph here shows you can see there's a position of the pubic symphysis here. There's a pubic ramal fracture here. There's also a rami fracture on this side. Sacroiliac joint here. It's also been affected. The iliac bone on this side also appears to have a fracture. And importantly, like we mentioned earlier, the urethra actually traverses this point. So not just urethra would have suffered injury here, the bladder, the bowel would also have been injured in this patient. Now, taking a look at the spectrum of injuries that could occur for a patient who has had a pelvic fracture. For the male patients, the anterior urethra would have injuries that will result from blunt or penetrating forces. And like I mentioned earlier, the bulbar urethra is the most common site affected following blunt trauma, usually from the fall aside or stepping on a manhole, or patients who may have been impaled against the wall by a fast-moving vehicle. Here, the bulb of the urethra is compressed against the pubic symphysis. That will now result in that tip at the prostatic attachment. Fixed or stratum injuries could also result in this. Now, these injuries to the bulbar urethra can be single. Usually, they are single and result in partial or complete strictures. The penetrating anterior injuries are usually rare and caused by gunshot wounds or stab wounds, dog bites, impalement, or penile amputations are the ones that usually result in this kind of injuries to the anterior urethra, penetrating injuries to the anterior urethra. Now, depending on the segment of the urethra and the nature of the inciting force, there's usually associated penile, testicular, or pelvic visceral injuries. And for the posterior male urethral injuries, they are either partial or complete and commonly caused by blunt force trauma. And the severity of the posterior urethral injury depends on the configuration or the severity of the pelvic fracture. And as we mentioned, these injuries are referred to as pelvic fracture urethral injuries, okay, and results in pelvic fracture urethral distraction defects. Now, when that happens and there's separation of the posterior urethra from its ligamentous attachment, there's like a retraction or ascension of the proximal membranous and prostatic urethra into the patient, and then the bulbar and anterior urethra seems to have fallen lower down and giving a gap between the disrupted ends. This gap eventually will get filled up with scar tissue and may give the impression of a long or a long segment stricture, as it were, between both ends of the urethral tissue. However, there's no urethral wall in that space. It's important to note that. There could also be associated injuries to the bladder neck and the prostate. Fortunately, these are rare because this will usually result in incontinence and erectile dysfunction for this almost inconceivably. And then there could also be concomitant injuries to the central nervous system, the chest, the abdomen, or the spine for this degree of injuries. For the posterior urethral injuries, you could also have penetrating injuries, most times usually from gunshots that are directed, or the pelvis gets caught in the trajectory of the bullet and it also damage the posterior urethra. But thankfully, these are also rare, especially in civilian setting. And for injuries involving the posterior urethra, it's always important to look for signs of intra-abdominal injury and signs to adjoining visceral or tissues. These associated injuries, whether blunt or penetrating, usually will govern the patient's resuscitation, the definitive assessment, and the treatment plan for this patient. The severity of the injuries will determine whether the patient will end up having a stricture or having continence, erectile dysfunction, and all of these have the definitive detrimental effect on the patient's quality of life. Now, in females, thankfully, pelvic fracture urethral injuries are rare, and they could be longitudinal or partial. And then the laceration could be transverse or a complete one. And thankfully, the flexibility provided by the vagina and the elasticity of the female urethra make it less feasible for you to sustain the degrees of injuries the male urethra sustains. And then usually when we have a pelvic fracture in a woman that has disrupted the pelvic ring, it's important to make sure that the urethra was not injured. Signs of urethral injury in a woman with a bleeding in the vulva when the patient is not menstruating, or blood clot at the urethra may have to attempt at urethral fracturization. And there could also be concomitant bladder injury to this patient, especially the impact happened when the bladder was full. And this now puts the female patient suffering urinary incontinence more from pelvic fracture associated urethral injury, and even a uretrovaginal fistula. If, for example, a bone speckle pierced both cavities, giving a tract for a fistula to form. Destruction injuries are unique to injuries involving the membranous urethra and proximally. And usually we describe it in men, like when one is plucking an apple off the stem. Okay? Like I was trying to explain earlier that on impact, the rupture of the prostatic ligaments, makes the prostate, prostatic urethra, the membranous urethra seem to ascend into the pelvis of the patient, and then the bulbar urethra and the anterior urethra seem to have descended lower down, making it look as though most times the injuries occur at the apex of the prostate. However, studies have shown that the most frequent point of destruction is at the junction of the bulbar and membranous urethra, not at the membranous and the prostatic urethra. And these destruction injuries can involve any part of the urethra from the vulva to the bladder neck. In men who are post-pubescent, thankfully it's rare to have injuries that involve the prostatic urethra. However, for men who are prepubescent, there's likelihood of prostatic urethral involvement if they have this kind of destruction injuries. Despite all of this, studies have also shown that there's still a strip of epithelium connecting both tissues, the proximal posterior urethra and then the distal bulbar and penile urethra. There's usually a strip of epithelium left that now forms like the bridge on which urethral realignment takes place. Now, in evaluating a patient who has sustained a urethral injury from a pelvic fracture, the order of evaluation and treatment is directed by the ATLS protocol. The management or stabilization of the pelvic fracture and any other associated life-threatening injuries. Those are the priorities for the patient. Other things on the evaluation of the patient that will point to or suggest to associated urethral injury is usually history of either blood at the tip of the urethra, blood in urine, painful inability to urinate with a suprapubic swelling, or examination of the perineum reveals a hematoma, and then the talk of a high riding prostate, which is not a synchronon though, but it's part of the things that sometimes are reported. If there's facility for doing a retrogram, a trauma setting, if the patient is hemodynamically stable, a retrogram will help you to demonstrate if there's a urethral injury using the Goldman's criterion and the ESC classification. So looking at looking out for presence of extravasation at any segment of the anterior or the posterior urethra, that urethrogram will help identify. And then if there is no extravasation, a urethral catheterization can be safely attempted. Okay? However, if there's no urethral facility for a urethrogram at the point of presentation, when the patient is stable enough to have one, a single attempt at rectal catheterization with a small size catheter can be attempted by the most senior person in the team. And if that fails, a plan should be made for urinary diversion with suprapubic cystostomy. There's also room for urethral alignment, that's reloading, for the hemodynamically stable patient. It can be done by coupling bridges antegrade and retrograding to align the urethra, okay, over and put a catheter in as a stent, okay, and then, or if one can do endoscopic realignment, using a flexible cystoscope to look at the roadmap of the urethra and then put in the catheter. For the management of the urethral injury itself, there's room for primary urethroplasty. However, this is mentioned to be started because the outcome from such approaches have been poor. There's usually a high rate of breakdown of the anastomosis because it's done when the patient is likely not fully resuscitated. There's higher risk of erectile dysfunction, higher risk of incontinence to the patient. So primary urethroplasty, yes, in some very rare settings may be argued for. However, it's not done. There's also the room for delayed where one waits for about 2 weeks and attempts to do a primary anastomotic with connection of the distracted segments of the urethra. That's also has been shown not to have very good outcomes. And then, of course, the deferred one where it's planned after patient has recovered from the pelvic fracture, any other associated injuries, from 3 to 6 months post-trauma. Patient will have been on a suprapubic cystostomy, and then subsequently the urethra will be characterized, and then a definitive anastomotic urethroplasty will be planned for. Yes, just to reiterate, it's important to define the anatomy of the pelvic fracture before it's treated by the orthopedic surgeons, and such fracture should be stabilized, and the identification and management of any other life-threatening injuries that the patient may have following the injuries that resulted or accompanied the urethral injury must all be sorted out. And then subsequently, from 3 to 6 months post-injury, the stricture is characterized using retrograde and antegrade studies as indicated to find out the number of stricture points, because you have both anterior and posterior strictures. To find out the length of the strictures, will it be amenable for excisional anastomotic stricture? We need to do a substitution urethroplasty for the patient. And then the location of the stricture will also determine the kind of morbidity the patient will have from the primary injury and also possibly from intervention from urethroplasty. And then, of course, any other associated injuries are identified and managed accordingly. This here is, I guess, photographs showing us how primary endoscopic alignment may be done. Okay, so the cystoscope is put in via the SPC, okay, and one looks in there, and then you advance the catheter from the urethra, and then, of course, it is pulled into the bladder and inflated subsequently. The catheter there just acts like a stent and a drain. The other option is to put in interlocking sounds to sound out, couple the sounds together so that one can pull in the catheter into the bladder from there. Usually it makes placement of the catheter more straightforward. Okay, and the catheter just serves to align the obliterated or distracted urethral ends so that subsequent reconstruction is better facilitated. And that's just a guide, as I said, and act like a drain so that when the pelvic hematoma that occurred around the site of the urethral injury, as it organizes and liquefies, the presence of the catheter, reduces or makes the process of inflammation less long. Okay? And then at the time of primary repair, the ends of the urethra that we have been injured are not so far apart and buried in scar tissue. Well, some have reported that some patients seem to void well following removal of that catheter, but still, over time, they develop stricture formation and we still need definitive repair. So the catheters are there not as a way to treat the injury or prevent the stricture. The fact that the urethra has been injured means that it's going to have to heal in a manner that will result in inflammation and fibrosis that will lead to loss of sensibility and narrowing of that segment, abnormal narrowing of that segment of the urethra. So the location of this distraction injury is an important factor in determining the continence of the patient after reconstruction, on top of all the other associated injuries or mobility the patient may have sustained from the injuries. The length is also important and needs to be determined as precisely as possible proactively to plan. And contrast studies at the first line tool in the evaluation of the pelvic fracture rectal injury, right from the uretrogram that can be done in the trauma setting and presentation if the patient is hemodynamically stable, and then the retrograde uretrogram studies, the micturating uretrogram studies that will help delineate the proximal and distal aspects of the urethra to determine how much of a distraction the patient may have suffered. And of course, eventually, subsequently, even after urethroplasty, contrast studies will help ascertain the adequacy of the care that has been done. When these studies are done and contrast is unable to get into the posterior urethra or even into the bladder, it suggests that the bladder neck has been injured. The retrograde uretrography is the one that helps us evaluate the anterior urethra most. This here is a retrograde study. You can see the smooth outline of the penile urethra, then the bulbar urethra down here. You can see the smooth rounding of an abrupt cutoff of contrast on this side, showing that this patient has the bulbar picture that is complete. The one to my left here is a curating film. You can see air and the dome of the bladder where contrast was still where the SPC. Here we can see the outline of the bladder from the contrast, smooth. The bladder neck seems to have opened here, but there's this island where there's no contrast. It just helps to confirm to that patient's picture is complete. Okay. Even when the patient was asked to try to micturate, we can still see there's still this island where there's no contrast between the proximal urethra and then the distal bulbar and penile urethra. The goal of management for all of these patients after the orthopedic injuries, the chest injuries, the abdominal injuries may have been sorted out for all patients usually is to try and give them a primary anastomotic reconstruction of the urethra. And the time frame for this is determined by the type and the extent of the injuries the patient may have suffered. But for those patients who may have done well from their associated injuries, the urethral injury or stricture that will have formed now, it can be done from 3 to 6 months post-trauma. It's important that this other injury patient may have suffered should be treated before putting the patient up or send the patient to the urologist to manage the urethral injuries. In most cases, the pelvic fracture urethral injuries are not long segment injuries, like what we see in the anterior urethra that usually from infection or from catheter. And usually they are technically straightforward to reconstruct, and the achievement of a primary anastomotic technique usually helps solve the patient's problem. The principles for the uretroplasty involve us making a spatulated and stented anastomosis of the proximal urethra to the prostatic urethra. This repair must be tension-free, usually an end-to-end anastomosis, and should be watertight. For the posterior urethra, the patients are usually in exaggerated decoupling position. The urethra is mobilized proximally and distally. If that is still not enough, the intrapleural space can be further developed to gain some more length. If that is still not enough, we want a tension for repair. Inferior pubectomy is done for these patients, and this is where we need our orthopedic colleagues to sometimes join us in the management of some very deeply seated posterior urethral injuries. And if that's still not sufficient, sometimes the urethra may be routed around one of the corpora to gain some more length. And usually at the end of the day, the primary end-to-end anastomosis is actually for the patient. Okay, this picture depicts the injury, the pelvic fracture urethral distraction defect that has given a gap about 2 centimeters. Okay, and then, like I mentioned, the proximal part is spatulated, the distal part is also spatulated after mobilizing the urethra. Okay, and then if that is still not sufficient, part of the pubic bone can be taken off to give us some more length, and then usually we're able to achieve primary tension-free anastomotic reconstruction. Usually this is done over a stent. The silicone catheter is a stent, and urine is diverted via a subaqueous cystostomy. And then urethral catheter is plugged, not meant to serve as a drainage passage for urine. Patient receives antibiotics and analgesia as indicated, usually a perineal drain that will be taken out once it has served its purpose. Following reconstruction, these patients are usually allowed to ambulate about 48 hours. And if all is well, there's no fever, the wound has healed well, the skin wound has healed well, patients usually allowed to go home with a subaqueous catheter, and the urethral catheter is left in place for about 3 to 4 weeks, at which time a pericatheter ureterogram is performed and examined to ensure that there's no extravasation and that the point of reanastomosis appears widely patent. A culture specimen for urine is also obtained, and then the subaqueous catheter is blocked, the urethral catheter is removed, and the patient is allowed to void. The adequacy of these voidings are judged by uroflowmetry assay, and then if adequate, the subaqueous cystostomy will then be closed. The patient is followed up 6 monthly, 1 year later, can be evaluated using flexible ureteroscopy to be sure that the lumen is actually patent, and then of course uroflowmetry to assess the flow rate. At this time, it's considered that the reconstruction done is mature and should be widely patent. However, for some patients who have suboptimal outcomes, if the uroflowmetry done post removal of catheter is adequate, they are taught intermittent self-catheterization, and subsequently urethral dilatation as indicated are done for these patients and followed up. The complications for these patients who have suffered urethral injuries could arise from the primary associated injuries to the bladder, to the rectum, the vagina, or the bony injuries the patient has sustained with their concomitant infections, and sequelae from that, patient may need a colostomy to divert feces to, apart from subaqueous cystostomy. And then involvement of the gynecologist with the associated vaginal injury. Now, from the urethral injuries, especially for those that may involve the bladder neck or the prostate, the patients usually will suffer incontinence from the injury, and it's clear to let them know that it's a possibility, because they usually will need for a urinary diversion, and we cannot categorically see if they were incontinent from the injury. And then they could also suffer erectile dysfunction with pelvic abscess connection for unrecognized or not quickly recognize posterior urethral injuries. And of course, eventually, all injuries to the urethra will result in some form of stricture, apart from the distraction defect injuries, which we can't describe as strictures, strictly speaking. And then, of course, there will be complications from the interventions done for the patient, anastomotic breakdown, with ureteroperitoneal fistulae, pelvic abscess, there will be restrictor formation, vectomy done to result in ostitis, osteomyelitis, the shocking of the penis from mobilization or arousing of the pleura. There could be affectation of erection. The form of the pelvis could be affected, and then giving the patient chronic pain. The prognosis of these patients depends on the characteristics of the stricture and any associated injuries that the patient may have. If it's a simple type 1 urethral injury, for example, now, the outcome from that cannot be like the patient who may have had a type 5. The time of presentation to the specialist is also important. When patients present late, they usually by urinary extravasation, whether intraperitoneally or extraperitoneally, and all this affects the prognosis of the patient. Patients who may have comorbidities, those who may have immunosuppressive states, patients who may have uncontrolled diabetes or cardiovascular diseases, those of sickle cell genotype also will be affected, their outcome will be affected by this. And of course, the skill of the multidisciplinary team that is on ground to anticipate and prevent patients from as many sequelae that are possible from the injury, but also determine the outcome of this patient, including the ability to properly communicate to the patient the implications of the injuries that they have will affect the prognosis for the patient, because the urethral injuries usually almost always result in stricture formation, and the management usually is lifelong between the patient and his or her urologist. Summarily, urethral injuries from pelvic fractures are commonly post-traumatic from motor vehicle accidents, fall and stride injuries, or fall from height. Just frequently, the bulbar urethra is the most commonly involved part of the urethra in pelvic fractures. Injuries to the posterior urethra that usually result from pelvic fractures are called pelvic fracture urethral injuries, okay? And they result in pelvic fracture urethral distraction defects. Management of these patients is multimodal, multidisciplinary, depending on the associated injuries the patient may have. However, the ATLS protocol is very important to identify and treat other associated injuries and be life-threatening in these patients. In the emergency setting, when the patient is unstable, the urinary diversion via scapular is done to help the resuscitation monitoring, and of course to divert urine away from the pelvis. And of course, for the setting where we have the hemodynamically stable patient and there's facility for the emergency room program, that can be done to identify the urethral injuries. And then there's also facility for endourologic assessment to align the urethral segments that we have been distracted. It could also be used to disturb patients. The definitive treatment will depend on the characteristics of the injury of the urethra, with the goal being an asymptomatic urethroplasty. The patient must be informed that it's going to be staged management, and of course, of all the possible debilitating sequelae from the spectrum of injuries he or she may have suffered. These are my references. Thank you all for listening. Are there any questions?
Thank you very much for that wonderfully detailed talk. And if there are questions, comments, we can all just type in the chat box, or we can unmute ourselves, raise a hand, and then just ask. I had a few questions which I'd taken the liberty of typing down.
Can I go ahead with those now?
Please do.
Okay. First one says, what are the requirements for a retrograde ureterogram? And can orthopedic surgeons or emergency physicians order this once requirements are fulfilled? Okay. The requirement for a retrograde ureterogram in the emergency room is the clinical suspicion of urethral injury. It's the same way we order for our trauma series of X-rays. We just go, and then the radiographer puts in a catheter at the navicular fossa there, and then it spreads up contrast, and you take the film. So we are looking out for extravasation anywhere along this path because the contrast gets into the bladder, you know. So once the patient is fit enough to be moved to an X-ray, and there's clinical suspicion of urethral injury, these blood at the tip of the urethral meatus, history of passage of blood in the urine, the patient is voiding, or it tells you it's voiding well and the urine is bloody, or there is a hematoma in the pelvis. Those are reasons for you want to solve, or a painful inability to urinate following trauma. Those are reasons to suspect that the urethra has been involved or injured rather. And so one can add that investigation to the trauma series of X-rays if the patient can be moved from point A to point B to get them done. And then next question is, what is the best type of catheter to use for trial and size? All right. Well, the appropriate size for catheterization for the adults, we're talking mostly about adult patients now. If there's a size 14 silicone, the urethra should be well lubricated with minimum of 10 mils of lubricant gel, and then it should be gently introduced. Size 14 catheter is what one can use in that setting. Urology should be called when there's clinical suspicion of urethral injury, because he's likely going to be the one to do the urinary diversion, and most likely not the trauma team or the orthopedic surgeon, who are usually the first on call to see the patient. And they are the ones who usually identify that they suspect there's been a urethral injury. So I think the urologist should be called when, in the trauma setting, when there's clinical suspicion of urethral injury from the things I mentioned before: blood at the tip of the urethral meatus, painful inability to pass urine, passage of blood in urine, even if the patient is voiding well, because it may mean that the bleeding may be from the upper tract, may be a renal injury, may be a bladder injury. So that the patient says is voiding freely and there's blood in urine, one should still involve the urologist as early as possible.
Thank you very much. I wonder if there are any other questions or comments. Having said that, how often do you require to have pubectomies done for urethral injuries? Just to see if there's a market for us that we can tap into.
Okay. Well, I know there was, since I started my specialty training, there have been 2 instances when we actually wrote a consult to the orthopedic team, but my trainer was still able to get away with the other maneuvers to gain length without having the pubectomy done. So it's not, I've not had the privilege of seeing one being done before. So the maneuvers to gain length, usually routing the urethra over one of the crura, usually will give, and it has given the length needed to do a repair that's not under tension. Because the aim of all those maneuvers is to achieve retention-free repair. So I've not had the privilege of studying on one, but I know there have been 2 cases for membranous urethral injury or bulbar membranous urethral injury, where we had to do the procedure in that deep tunnel. It's really quite a challenging procedure. Um, and maybe taking away that inferior part of the pelvic bone is the mobility, and from that is what many of the urologists try to run away from, perhaps. Maybe that's why they are still they still rather reroute do chloral separation to gain as much length as they may need. And of course, there's room for some combined abdominoperineal approach for the more proximal urethral injuries. I also haven't had the privilege of observing one on close to, but it's described.
Thank you. Well, we'll keep it in view. There's another question in the chat box, if that's all right.
From my experience, which injury is commoner following pelvic fracture, bladder or urethra? Well, I think I'm not sure. I'm not sure how to answer, but I know that I've been on call to see both injuries, and usually the bladder injuries are more when the patient has been traveling or was hit with a full bladder. That's when you see more of the bladder injuries. The urethral injuries, commonest one, the commonest part of the urethra involved usually, thankfully too, is the bulbar urethra. Patients usually come in with that history of being either impaled against the wall by a car that failed brakes, or they were run over, or some heavy instruments fell over them, or it was a stab injury, And so for the pelvic fractures, the ones that come without associated abdominal injuries or chest injuries, the ones that come with pelvic fractures, history of being hit by a fast-moving vehicle, inability to bear with hematuria or blood article in the arteries. Usually it's the bulbar urethra that seems to get injured, and then of course they go into retention eventually, and then we do the urinary diversion to the supraplex system. However, those who may have blunt post-trauma that sustain abdominal injuries to other injuries to other abdominal viscera, for example, stomach injuries, bladder injuries, those they usually don't have associated pelvic fracture. From what I've seen, I mean, most of the bladder repairs I've done, or most of the bladder intraperitoneal bladder ruptures I've done, don't have associated pelvic fracture. But I think I should look into that and perhaps report.
Thank you. I wonder if there are any other questions.
I think these are all for now in the chat box.
Yeah. If there are no other questions, I suppose we can slowly start proceeding towards closing the meeting, but we'll give it a few more minutes for people to gather their thoughts, and then we will see. Meanwhile, I want to thank you very much for this presentation. It's fascinating that the urethral injuries are so much worse than I ever knew. I mean, looking at them from the perspective of the different grades and severities of injuries and how different they all are, it's actually quite a broad spectrum of just knowing that they're distraction injuries and they're around the prostatic area. The normal registrar stuff we learned in urology. So thank you for giving us this very detailed perspective. And if you ever need to have pubectomies done, feel free to just call. I will
Okay,
be
ma.
help you.
The orthopedic surgeons here they've been usually quite willing. At least they receive the consults and then wait for us to call them to explain them. But usually my trainers have been able to get away without the
Without- Or would you say then that
getting that.
perhaps an endoscopic realignment should be the first standard thing for every patient? Since it looks like it makes the eventual management easier for everybody, should that then be first line for all patients?
Well, I'm not sure if I am old enough to have an opinion about that, but if I would make to say, based on principle, okay,
Mm,
the patient who has sustained urethral injury with pelvic fracture must be resuscitated first.
yes.
So that is not the time to put him in lithotomy and then try and do, okay, well, not necessarily lithotomy because you're going to go in through the bladder with the cystoscope, okay, and then pass the catheter from the urethra, try and put it into the bladder and inflate and leave there, okay, depending on what the urethrogram may have shown. So the priority is for the identification and management of life-threatening injuries first, and then subsequently a urinary diversion, okay, because the endoscope is not going to come in through the urethra, and it's a procedure that patient needs to be fit enough to do to have like an SPC. So in this setting, I'm not sure how many centers have facility for endourology or have flexible cystoscope. In my center, we have a rigid cystoscope, we have semi-rigid ureteroscope, but that's not relevant here. So we don't have flexible cystoscope to use for this, which is the ideal thing to use in this setting. So the principle is to divert urine, and you need to do that for 2 reasons:
Okay.
to monitor the resuscitation and to divert urine to prevent extravasation within the abdomen or the pelvis. You know, if there's associated bladder neck injury, if there's associated bladder injury or bladder injury, the SPC will help you get all the urine out. Okay, and then the patient's resuscitation, secondary survey, tertiary survey can go on, and then we have that sorted out until the patient is fit for proper characterization of the urethral injury. You know, which is where the retrograde urethrogram for the anterior urethra and the micturating for the proximal or posterior urethra. So endoscopic alignment is, and then of course, doing all those things could also worsen the urethral injury, as it were. You know, there's damage to contiguous structures by introducing. There's a risk of hypergenic injury too in doing those procedures. So for the trauma patient who is not at his best, I'm not sure endoscopic realignment is advocated. It's not advocated. And then the risk of incontinence, erectile dysfunction, um, you know, could be higher following those interventions to railroad urethra. The potential benefit in view is that it keeps the proximal and distal segment of the urethra, aligned, so that the subsequent urethroplasty, they are not held down or tilted down by fibrous tissue and maybe not so far apart away from each other. And then, like I mentioned, the catheter serves like a stent to allow the peri-injury hematoma to liquefy and then drain out, and keep or reduce the risk of a pelvic abscess from forming. But all those things I'm not sure they are worth the risk of going to cause further iatrogenic injury or taking a patient to theater when may not be best resuscitated.
Thank you very much. The last thing, and maybe I'm not sure if you mentioned, is antibiotics. What are your thoughts on antibiotic prophylactic cover for these patients?
Well, I think that will be guided by the associated injuries a patient will have, because he has associated bowel injuries, the cephalosporins and metronidazole will be the antibiotic of choice because of that associated injury. But if it's purely isolated urethral injury, the quinolones uh, can be given first line. Though now here we are all moving towards the prescribed zones, even in urology at present.
Okay, that's good to know. Just so that we know that if we see urethral injury, at least we should think of what sort of antibiotic choice we would want, since most pelvic injuries would not routinely receive antibiotic cover, except if you suspect that, yes, you may have a huge hematoma in the pelvis and you want to give it for prophylactic reasons, in which case you would, like you said, it's weighing everything together and then I suppose deciding on a case-by-case basis.
Yes,
Thank you very much once again. I wonder if there are any other questions or if we can close the meeting and thank Dr. Odutola for her time.
Thank you very much to everyone.
And for